Assalamu alaikum everyone. Welcome to the 5th AEG Basic EUS workshop. I hope you all had safe travels. We will be starting this program with a tilawat by Dr. Babar. Aziz.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد صدق الله العظيم.
Over to Dr. Saad Niaz. Sir, if you could just... Testing 1, 2, 3.
Assalamu alaikum everybody. First of all, sorry, we are starting a bit late, mainly for, I think weather को blame कर देते हैं आसान है. I'd like to welcome you all. जो पहली दफ़ा आए हैं to our Sindh Institute of Advanced Endoscopy and Gastroenterology, and I'm very grateful to all of you for being here and allowing us to do this EUS course. Otherwise, it wouldn't be possible if you weren't here. Having said that, I'm very, very grateful to our international faculty, Dr. Khalid Hassan and Mustafa Rai, who have traveled and reached at 2 a.m. this morning. I don't know if they got some sleep or not, but आपको उनके काम से अंदाज़ा हो जाएगा कि उन्होंने, if they had some time to sleep or not. Khalid, I know, can work about 48 hours without sleeping. Mustafa is a little bit more like me, normal. I'm also grateful to Professor Ghiasun Nabi Tayyab, who's been part of our training program since we started, and Shahzad Riaz, who's come from Shifa Hospital, Islamabad. So I'm really, really thankful. And we hope that we'll have a good EUS course. I apologize, I'm not going to be hands-on, but I'll try and be here as much as I can with you all. Okay, so with that, please start. Thank you very much.
While Dr. Mustafa is setting up, can all the hands-on candidates introduce themselves and tell us what their US experience is?
Assalamu alaikum. Thank you for my name is Dr. I'm from Quetta as an associate professor at Bolan Medical College. So I'm thankful to the Professor Saad Khalid Niaz and his whole team, and also thankful to the international faculty who has traveled a lot and have to give us the hands-on training for us.
Assalamu alaikum. My name is Dr. Shakir Hussain. I am working as an assistant professor at AIMS Hyderabad. We have the US machine and we are doing basic US.
Thank you very much, Dr. Saad, for organizing this workshop. I'm Dr. Junaid, and most of my experience is with Professor Gyas. I have a lot of experience in observing the EUS, but have a very limited hands-on. So what I'm expecting to have a little bit of more of the hands-on experience in this workshop. Thank you.
Assalamu alaikum. My name is Dr. Mushtaq, and I am working as consultant gastroenterologist at Khyber Teaching Hospital, Peshawar. Last year, I have attended Peshawar, sir. Last year, sir, I have attended endoscopic ultrasound workshop in Siag as observer. This time, I am hands-on candidate.
Assalamu alaikum. Thank you to Professor Dr. Saad Khalid Niaz Saab and all team SIAG for this training workshop. My name is Afan Kesar and I am a assistant professor at Shahid Islam. All my in SIAG, and thank you for this opportunity.
Correct? Sweet.
Ganesh? Okay. Assalamu alaikum. Thank you for the invitation. It's a pleasure to be here once again. मेरी टॉक्स पाकिस्तान आके मिक्स्ड होती है इंग्लिश उर्दू, तो बेयर विद मी बिकॉज हमें कम ही मौका मिलता है. वैसे खालिद भाई मैं इकट्ठे होते हैं तो वी डू टॉक इन उर्दू अलॉट, लेकिन ये है कि आई विल ट्राई एंड कीप दिस सिंपल बट दे आर समवॉट डिटेल्ड. And unfortunately for you, you have to put up with me for 2 back-to-back talks. So अगर नींद आनी शुरू हो जाए तो प्लीज़ हाथ खड़ा कर दीजिएगा, तो we'll take a break. We'll start with principles in knobology. I think the first time I came to this course is the first time I actually prepared this presentation, और उसमें मैंने काफ़ी सीखा. And I think the point of the matter is that we have a tendency to jump into procedures, but you have to step back, understand the basic principles, and then move forward. And I think that leads you to have a good foundation on which you can then build. And it starts with what is the definition of ultrasound and what are we actually doing here. So agar aap dekhen, so there, when you look at lights, dim ho sakti hai, is this how it's going to be? Either way it's fine. And I don't know if this laser pointer is actually going to show up there. Agar dekhen, the sound that we hear, the audible range is in the 20 to 20,000 hertz frequency. Ultrasound just means, higher frequency waves, and we're looking at anywhere from 2 megahertz, so 2 million hertz to 20 million hertz. Most of what we do is in the 7.5 megahertz range. That's the default setting on the EUS scope. So just remember, we're just high frequency waves, These are being generated, there's an electrical current being generated by the endoscope, which has these crystals. The crystals then create these waves. The waves bounce off the tissue, come back, and are converted back into an image, and that's the principle of ultrasound imaging. Some principles of ultrasound overall are that the best image you'll get is when the wave hits something head-on and comes right back at you. So practically speaking, if your probe is on the lesion in the right place, that's when you're going to get the most optimal image. If it's to the side, then you won't get the best image. That's basic principles. So your best reflection is going to be head-on. If you do have images that are not very clear, that's probably because the waves are hitting at an angle and there's refraction instead of reflection. So that's going to give you the artifactual images, and that's how we see artifact. The other important concept is scatter. So what happens is you have different densities within a tissue. So if you have the liver, for instance, you have fat, you have cells, you have blood vessels, and proteins, so different sort of molecular structures, and they will all transmit the waves back at different sort of frequencies. That composite image is what eventually comes back to us as an echo texture. So we talk about hyperechoic, hypoechoic. More fat will be more hyperechoic, meaning it's more bright, because most of those waves will get scattered. Fluid will transmit the wave completely, so that's going to be anechoic. And most solid tissues will have differences in echo texture. Masses tend to be more solid than liquid, so they'll be darker, they'll be hypoechoic. So this terminology is important. Hypoattenuation, radiologist, is there any radiologist here? You know, there's all these, they use these different terms. In CT scanning, they call attenuation, hypoattenuation. In ultrasound, you use echo texture, hypoechoic. So it's an echo structure. So just signals, so just keep that in mind. Okay, secondly, how does it work? In sort of very basic fundamentals, when you hit a wave, you hit an ultrasound wave at something, it comes back to you as a waveform. That's called an A wave. Here we're converting that wave into an image, and that's called B. So B mode, you'll see this all over in ultrasound sort of text. B is brightness. That's all it is. You'll see the big knob which has a B on it. That's because that's for brightness. So the ultrasound image is converted from a wave into a sort of image, and that's called, the ultrasound signal is converted from a wave into an image, and that's called the B mode. As you move the transducer from left to right, the image will basically mimic whatever is being seen in the wave. So as you go from left to right here, you'll see that the transducer from here, this is the path it creates. If you look at the A wave, there are different frequency waves, and then the image is converted, or the waves are converted into an image, and they'll show up like this. So based on the density and the various features of the lesion, you'll get a different image. So that's how it works. And the brightness of the image can be changed with that dial which has the B on it. That's the gain. So you increase the strength of the image by turning up the gain, and then you'll get a brighter image. You decrease it by turning it down, and you get less of an image. All this makes more sense, you know, when you start doing cases too. You also have fine-tuning, just like in anything else. You have the big dial. This is on the bigger machines. The big dial for the overall image gain, and then you have these fine-tuning sort of measurement areas, which are basically distance from the probe. So if you look on the right side, each little knob here is a certain distance depth-wise from the probe image. So if you want to fine-tune a certain image because you're getting artifacts say close to the tip of the probe, then you can adjust this. If you want to go further out, you can do this. And it's got different terminology based on which company uses it, but STC, spatial time compensation, is a concept to be aware of. So it's not just put the scope in, jo nazar aa gaya kar liya, baat khatam. You know, you have to optimize your image because you're dealing with a patient's health. So it's important to make sure you have the best optimal image, the best product that you can get for the sake of the patient. The other concept is resolution. So axial resolution means when you have two things in the same line. अगर मैं इधर से ultrasound भेज रहा हूँ तो मेरे सामने 4 लोग बैठे हैं. So those 4 people the wave that's going straight ahead, the frequency of the wave at which the image is, the ultrasound is being transmitted will determine the resolution. The higher the frequency, the clearer the image that I will see of 1, 2, 3, 4, but the less the depth. If I go really high on my frequency, then I can maybe only see 2 people. But if I decrease the frequency, they won't be as crystal clear, but I will get more depth. So the concept to remember is high frequency, cleaner image, but you can't see as deep. When you have lower frequency, you have more depth, but it becomes more fuzzy. That's the basic principle of this. Again, the standard frequency on a linear scope nowadays is 7.5 megahertz. So it's somewhere between that 5 and 10. When you go to mini probes, those are little probes that you can put through the scope. They go up to 20 megahertz, and you can get very clean images of submucosal lesions. But if you want to look further into tissue beyond the luminal wall, then you don't benefit from those probes. Lateral resolution is, if I'm looking down here, now I want to see sideways. So now what's going to matter is basically the probe itself. What's the field of the probe? That's going to determine how far I can see. And then there are other settings that are predetermined on the machine. We don't really adjust those settings. So those basically will be based on the field that you have, and then the probe and the equipment that you have, the scope as well as the machine that we have. So lateral resolution is not so much in our control, that's predetermined. The axial resolution, the depth-wise, we can adjust it based on what we're looking at. Another concept that we all need to know about is, of course, Doppler, because we are differentiating a fluid cystic lesion from a vessel. Sometimes you can't tell. You're about to FNA, is this a vessel or not? Or sometimes you're doing it to figure out, is this a vessel or not? And the principle with Doppler is that the frequency at which moving objects will transmit waves back varies based on their speed. And secondly, that if it's head-on, you're not going to get a good sort of movement factor. If it's at an angle as opposed to an image, Doppler is beneficial when you do have an angle as opposed to being head-on. So as something is going from right to left here, the faster it goes or the slower it goes, the frequency at which the waves will come back will vary, and that's called Doppler flow. And then you have different types of Dopplers that we'll demonstrate to you during cases, but you can look at the directionality of the flow, you can look at the strength of the flow, you can also look at sound, and you can look at the waveform. So you can differentiate arterial from venous, and portovenous versus systemic venous. So there are all these different settings that I won't waste too much time on. Okay, so equipment-wise, basically there are 2 different types. You have the small machine, which is the the EUME. We're just talking Olympus right now. EUME2, or their newest one, EUME3, which is basically a little box similar to our regular endoscope light source with a keyboard. And then you have these big machines, which have a lot more features. They're a lot more expensive, and depending on your setup, obviously you may have one or the other. In Pakistan, for obvious reasons, we have more of the EUME2s and 3s. They can be put onto your cart with the rest of your equipment, and then you can do your ultrasound along with your other procedures. And then you have these are somewhat sort of dated pictures, but basically you have this keyboard which allows you to adjust a lot of these settings that I mentioned to you. So the big one is freeze. Just in the corner on the right side, you can have a live image, or you can freeze it, just freeze on, off. That's simple. Next to it, you have the gain setting. Sorry, the image size. So you have depth, so you can see how deep, how you go with your ultrasound image, and we'll demonstrate all this. So I'm just going to run through these. You can make your image bigger or smaller based on the lesion. And then you have the gain setting. You can adjust gain based on the brightness of the image. And then within there, you actually have this STC menu too, so you can now do fine-tune adjustment of your image. You do the main gain, it's the bigger focus, and then the fine focusing you can use STC for. And this is how gain can affect your image. So if it's too bright, too high a gain, you lower the gain. If you're just not getting if it's too sort of I guess clarity is not as much, then you can reduce you can increase your frequency, and then you can adjust your STC setting to get the optimal image. For me, actually, and then the other thing is your eye gets used to a certain optimal image for your brain. For me, none of these is perfect. I would have, honestly, I mean, like, and also the projection on my screen versus this is not ideal, but mine would be probably somewhere in between these two, these top two, these diagonal two, because I think these two are too bright, but they're especially bright on your monitors. On the computer, they're not as bright. And then the frequency, as I mentioned, you can adjust. And then flow settings. I think I'm going to skip a lot of these because we're going to show these to you. But color flow, power flow, age flow, etc. And the key I think is important is the power flow, where you can actually look at waveforms. If you're looking for staging, is this an artery that is being encased or a vein? Put Doppler on, and you can tell which one it is. And because sometimes it gets really confusing. You have a mass, you have these blood vessels, and you're trying to figure out, okay, is this an artery or vein? And you can actually tell that because arterial involvement obviously is a bigger deal than venous involvement in certain situations. So that's the power wave, and then you get the waveform. Okay, moving on to the scopes. This is important for everybody to have basic concepts about. Linear, radial, and just for comparison, EGD. And the first thing you notice is that the echo endoscopes are much larger than your regular scope. If you look at the diameter, the EGD scope is 9.8 millimeters wide. This is on the Olympus scope. If you look at the radial, the tip is about 11.5, but at its maximum it's about 13.6 to 13.8. And if you go to the linear, even though the tip is 12.6, that's just the insertion point, but at its widest it gets to 14.6. So what you have to remember is, it's not necessarily the tip that matters. The tip is good for intubation of the esophagus. But beyond that, if you're going through tight turn strictures, it's the width, the entire width of the scope. And the worst thing we can do, well, one of the worst things we can do is, in trying to get to a place, especially in a cancer patient, we go through it and perforate the patient's esophagus or duodenum, and then the patient's been set back a lot. So point being, if you've been sent a patient for staging, it's okay to say, you know, my scope did not pass the stricture and pull out. Temptation ये होती है कि जी भेजा EUS के लिए, we have to stage it, let's get across it, do something to figure out ताकि इनको बता सकें, but you have to just say, this lesion, the principle of esophageal cancer is, if your scope can't go through, it's T3 at least. So you know by definition by then it's T3, and you can get a CT scan, you can get a lot of other information from other imaging modalities. And there are all these tables on the websites of these companies that can give you things. The other thing I want to just share is how the scopes work. So things to know about, we'll use these terminology, big wheel towards you, so that's flexion, big wheel away from you, that's extension. But remember, these tips are long, these are not your endoscope. So there's several centimeters, 4 or 5 centimeters of tip that you're working on. The other is left lateral movement. So we may say, you know, move your small dial to the left or to the right, or towards you and away from you, and that'll give you sort of lateral movement. This is good for gallbladder scanning. You know, if you're in the bulb, when you're looking for the gallbladder, you're scanning it, this is a good movement to do. These all start backward, upside down, but they actually project well. The other is, a lot of this has to be fluidity of movement with your left arm. The tendency is, because I'm colonoscopies करते हैं, colonoscopy is all about right arm, torquing, twisting, ये सब. This is the opposite. Now you have to let go of your right hand, let the left shoulder do the work. Start with the big joint, then the elbow, then the hands and wrists, okay? The shoulder does a lot of the work because that's the largest joint, you get the most range of motion. Then if you're stuck in a place, then you can do this, and then the wrist can be for fine tuning. But the key is the right hand is playing a supportive role. The right hand is supporting your scope. It's not really doing anything. If you look at the tip of the scope, a lot of movement, all that movement is coming from the left arm. So that's something we have to train our brains to do. And the flip of it is that if you're too tense on that right hand, then what's going to happen is, now I'm holding it very tightly and the movement has suddenly reduced because whatever my left hand is doing, it's being countered by my right hand. I'm just going to play that again. So that the point is, if you are too tight on your right hand, that's gonna not allow you to accomplish what you want to do. These are the principles that you are here to learn about. Okay, you're not here to master therapeutic EUS. Okay, that is what the vogue is right now. Everybody's talking about, I did this many axios, ये डाल दिया, वो डाल दिया, वो सब ठीक है. पहले देखना तो सीखें, scope हिलाना तो शुरू करें, फिर then we'll get to those stages. So really our emphasis is going to be on this. And sadly for the hands-on people, whatever kind of a nicer person I was 5 years ago, Saad bhai mujhe कहते हैं तुम बहुत soft spoken हो. So things have evolved. 5 साल हो गए, बच्चे बड़े हो गए and teenagers. So now you guys are going to get a rougher version of me. तो तैयार रहें आप. See, ठीक है? So be ready for some harsh teaching. Harsh teaching. Or maybe bad influence, yeah, with my colleague, who I love like he's my brother. So, दूसरा ये कि you have the elevator, your needle will go up and down, and you obviously for sampling or therapeutics you do that, and then you can also lock your dials. Again, you'll have different people have different preferences. Dr. Hassan does not like to lock his needle when he's doing sampling. I like to lock it, especially for trainees, because I want them to be stable. I don't want them flapping around in the wind and not hitting the lesion. So I'll just say, listen, if you're stable, lock your big wheel, use your elevator. The key thing which Dr. Hassan recently pointed out when we were talking about this with our fellows is that when you do that, sometimes with some of the needles, when you have it locked like this, and now you're trying to advance your needle, it can damage the scope with the softer plastic sheets, so you don't want to damage it. So you have to be cognizant of those things, and those things come with time. You can see with one of those needles with the plastic sheath, you can actually see on ultrasound, the sheath is like this and your needles come right through the sheath. So you have to be careful with those principles. So this is like back-to-back talks. There are 2 conclusions, but the first one is understand the theoretical principles, scope movements, and the machine. That is a prerequisite. If you don't understand those things, you're not really ready to start. It's like driving or something. You need to know the gears, you need to know where the lights are. ये नहीं होता कि गाड़ी में बैठो और चलानी शुरू कर दी. Practice makes almost perfect. We're all human. We all make mistakes. And to this day, I can tell you every year, I have a few things that I think about a lot and say, I could have done this slightly differently and patients would have been better off for it. And we're always learning. So that's the conclusion of my first talk. Any questions, feel free to ask. Saad Bhai is ready to answer them for you. जरूर जरूर जो साइड बाय साइड या वैसे ही सॉरी
मेरा पॉइंट सिर्फ ये था कि most of the centers in this part of the world are actually reusing needles. Okay, and the point that they were making, Mustafa made, कि अगर आप especially this is even more valid when you're reusing a needle. If your needle is not coming out very smoothly, do not force it. You're going to damage your scope. So if it's not coming out, then readjust your sheath, bring it out, and you will see your needle come out very smoothly. This is very important in the early times because you feel KRHA and you lock your wheels as well and agree what it is. But I think this becomes even more important when you're reusing needles. If you're not, then quite often you don't have that problem unless, of course, you're very difficult angle. So that's something that I think you should keep in mind if you're going to do it.
Maybe I just point out.
हाँ हाँ जरूर.
Yeah. Just looking at these scopes, you will hear during the cases as well. Usually scope, the camera and light is right in the front, right? You're looking at it and you're moving forward. With the EUS scope, even the light with the camera is at least a centimeter and a half to 2 centimeters behind the end of the scope. So keep that in mind. And ERCP scope, we call it a side view scope, means you are looking at the beginning and moving forward. ECD scope, you're looking forward, a front scope, and looking at the stuff that way you are going. EUS is right in the center. If you look at the camera and the light, they're pointing where the wall and the ceiling is meeting. So that's one point. This point is important because when you're going through the pylorus on one and apex, if you are looking at it, your toe is almost 2 centimeters away from that. So before your camera gets near your scope is coming. And the other thing was Paul kind of pointed out, chronoscope you are all over, but EUS, you have to online bronchoscopy, and really it's a very, very fine movement, very small movement of your shoulder, your wrist, and your elbow, and mostly it's going to be the shoulders movements which are going to be, and it's a very, very fine movement. So it's not, if we tell you move a little bit to the right, that doesn't mean all the way to the left. That means a little bit to the right. So these are small movements are going to be. So the other thing that I think is important that when you're doing it now, you have this tendency to put your finger on the air. And air is the
Yeah, absolutely. Yeah.
you don't want to have your finger on the air. Okay, you have to keep reminding yourself. It takes time before you actually get rid of it. So the natural tendency on subsea, you want to. You don't have to see the endoscopy pictures mostly, only for passing through certain parts or understanding where exactly you are. And then you need to make sure that you keep reminding yourself.
I like to use it.
Okay.
Yeah.
So I like to use it too. So as here is the hand ultrasound. Angel scope, the images that is perpendicular to the scope. So image like ultrasound waves are going this, and unless you put a balloon around that area, and if the fluid is here, it does not hold. Next to the wall and the right here on the other hand, some people say use it but some say you don't need to, and I think both are correct. For me and most of us, we both use the balloon and needle. And the reason for that is sometimes you're in a tough position and you do everything to put your toe right on the tissue right onto the middle of the wall. Still, there is some gap here, and that really not through the taking the gap area. We like to use the middle gap. If we're using a linear, for any sunny resolution, but we probably won't find too much nowadays. And suppose the percentage is you have to kind of money in the blue and the linear. So what is that sunny resolution and also for stable purpose, you know, and staging and staging the moon house. So that's what we can be use it, but for linear, you can use it.
Yeah.
तो मैं एक्सप्लेन कर दूँ यहाँ पे हमारे साथ एक्चुअली अंडरस्टैंड ट्रेनिंग ऑफ हमारे तो थर्ड लेवल नई ट्रेनिंग हमारे साथ लेकिन हमने कुछ चीज़ें यहाँ के लोगों से ट्रेनिंग करी वी कैन नॉट यूज इट फॉर सिंपल रीजन दैट द लोन इज एन एक्स्ट्रा कॉस्ट फॉर ये there are certain situations where the loan does help and maybe when you have an unstable growth condition, so you have a situation. That's the place where you may find that it is of an extra benefit. Important thing is the way you train yourself and where you get yourself used, you're going to live with that. Because of the medical training, we have learned to live without the loan, and we are pretty happy with that. It's really ever that we find a need to use it alone. But if there are certain issues where the loan does that, I think with college, there will be by the position where I would have found myself to do in a difficult
when I start some training, so when you are new to this, you want to do everything perfect. You want to do everything. You get overwhelmed by the number of notes. I had that problem. So when I also said that, which is very true, that this machine is actually a mobile ultrasound system. It can be used to do people, to gynae and other things. Because we have lots of things on it. 90% of it we don't actually need. And actually, there were a few days in which my soft touch, but actually you don't need that much. And most of the machine there's also a button as well. You just click on it and it will do everything for you. It will adjust the gain and the focus and everything for you. So don't get overrun by the number of knobs. There's only one or two that you really need.
Yeah.
But if I'm the same guy, ultrasound value only. So sound is very key for you. People don't want to see what that is. And they point to a very small vessel in the corner, like 6 miles away, and they want to know what that is. So
इमेजिंग पे सीटी और एमआर पे कुछ में बताया कि आपके काम में जाकर उसको देखना देख के तुम्हारा कंफर्म करना और उसके ऊपर बात करने को यूज करना बाकी ये चीज़ अगर खालिद साहब है मुस्तफा साहब है बात हासिल वो है
focus on the things which really matter, and that's what we're going to work on. Like the bigger thing, that's what we need to know. A small tiny level here, we have CT scans, we have MRI, which are much better than EUS to determine that. So that's what we're going to focus on the basic part.
Okay, so it depends, I think. अगर आपके पास support system है, especially early days में, it's much better to have the patient, under propofol or GA or whatever service you have. But you can do EUS. It's very interesting. लगता है, when you feel the scope, the thickness, and everything wants to go down, patients tolerate the procedure very well under sedation. But if you're doing therapeutic procedures, of course, it's much better. I think it's much better to have the patient under. So we have the facility here. We have a entire anesthesia department with the professor now. So we have everybody now. Almost all of them are under. But you can do this. I think it's done a lot of cases before with the midazolam, but you need to be careful. Midazolam, I think you need to have a low threshold. A lot of people I have seen in this city who would go up to 10 milligrams, 15 milligrams of midazolam with 15 milligrams of skin. And that's very totally unacceptable. And maximum 3 milligrams, 2 to 3 milligrams of midazolam and or 2 milligrams of skin is all you need in most cases. If you think that the patient is not tolerating, there's no point doing the EUS. They're constantly moving up and down, especially in early days of the surviving.
Just on that point, sentinel is better. It's just like in England, you get sentinel labs, but we don't get sentinel labs or sentinel. We tend to use London as the lab, but it's not as good. It's not as good. It's a magnificent.
जो मर्जी हो तो इम्पोर्टेंट the patient should be comfortable. And मैं तो this may not be first and last procedure. उसको बुरा ही पेश देखना है.
There is point पे मेरे अगर सर्विस का बात की तो मैंने पता है यूज करो तो सर मिलता है तो दिया जाता है.
चलें, I think
अगर काटते हुए अंदर में किसी सर्जन के लिया तो मुश्किल हो जाएगी.
Yeah. You can do it either way. I think that the needle sheath has to be out. You can't have the sheath inside. So you see the sheath by the probe. Dr. Khalid's going to give a talk on this as well. और मुझे signal भी मिल चुका है कि we're behind. So, but definitely we'll be going over all those features of sampling. The normal anatomy, this can be overwhelming, and I'm going to try and run through this quickly, which partly because you're going to see a lot of this in cases anyway. But essentially, and the big sort of message here is you have the luminal side and then you have the extraluminal structures, including most commonly the pancreas, biliary tree, liver, lymph nodes, and then incidental organs, जो कि adrenal पे 15 minute लगा दी लेकिन pancreatic mass देखा नहीं. So we don't want to do that, right? And then the vasculature. Just to luminal principles that we need to know, there are 5 layers in most structures other than the esophagus, and those in to out. The first one is the fluid mucosa interface, that's layer number 1. Then you have the muscularis mucosa, that's the first dark layer, that's layer number 2. Submucosa, which is bright, so lipomas will be in the submucosa. That's layer number 3. Number 4 is muscularis propria, and 5th is serosa, subserosa, except for the esophagus, where you will have adventitia. And presumably we'll have cases that we may have that go over this. Mediastinum is actually relatively easy, partly because it's a smaller lumen and you don't get, your scope doesn't fall out of position, so you can actually make things out more easily. Radial views are similar to CT, but just have to understand that it's a slightly different perspective. And you're looking again at mainly lymph nodes from our perspective, but there are all these vessels around that we should be able to identify. So here's a image from a textbook where the round red circle signifies your endoscope, echo endoscope. And so this is on CT, and this on the right side is your EUS image. And you can see you have, if you bring the spine to 6 o'clock on ultrasound, and we can show it to you if we have a radial, then you can orient yourself. Aorta to the left, azygos to the right, trachea in front of you, and spine below you. And then you go up and down. The reality is, because you cannot sample with the radial, we don't use it that much. A lot of us will go straight to linears unless there is like a staging question that we really want more detailed information on. And so I'm going to come to linear. This gets a bit confusing, but try and bear with me. And doing this in 20 minutes is going to be challenging. But I think it's worth trying to explain these principles. You have your patient laying on their left side. The scope is coming down like this. What I've tried to do is do a CT sort of equivalent of that. Your scope's going to come in like this, and next to it is your ultrasound image. So when you come down here, left is down, right is up, and basically what you're going to see is your probe is down, coming down this way from the esophagus. It's going to look down. And if you look at the structures on CT, left atrium, left ventricle, pulmonary artery, aorta, and that's exactly what you're going to see. Left atrium, left ventricle, pulmonary artery, aorta. This is towards the G junction. Okay? This you can only get with repetition. आप लोग 3 दिनों के बाद जब वापस जाएंगे, you'll be like, यार ये तो कुछ हमें समझ नहीं आ रही. I can tell you the first 6 months I was struggling in my fellowship. It takes a lot of cases to figure out, understand, but if I think back to my training, I think if I'd been given some radiology type of images for orientation, it might have helped. At least at this stage, I feel that way. So this is what I tried to do here. This is, again, a textbook image, but what I've done is put the CT next to it, and what you see is different levels. So depending on where your probe is, if we go from proximal to distal, you're seeing the descending aorta mainly. As you go to B, you're now looking at the left atrium and the mitral valve. C is the image that I showed earlier, where you have the left atrium. This is important. I'll tell you why this is important, is because the mouse is going all over the place. This view is important because this is right below the trachea, and if you pull back a tiny bit and spin around here, you'll see lymph nodes. That's level 7 subcarinal lymph nodes. So it's important to be able to identify left atrium, left ventricle. We'll show you these things. Pulmonary artery, aorta, and then this is station 7. And if you pull back further, you can actually then look at station 4L5, where your basically probe is now looking to the left between the aorta and the pulmonary artery, and you can basically look for lymph nodes. Isko AP window bhi kehte hain, in this area. So these are good for basically mediastinal lymph nodes. I'm going to try and do the same in the abdomen. What I'm going to show is fluoroscopy of where our scope is, where our anatomic structures are that we're looking at, and then show you ultrasound images. So now you're just past the G junction, you follow the aorta down, and what you see is, if you look on the CT, the 2 branches of the, so you see the branches of the celiac artery and the SMA coming off. And I hope this isn't messed up because they're supposed to be, oh, sorry. This is supposed to show next here. Right? This magic. But I'll show it to you in a video in a second. Now when you go leftwards from there, so now you're going, so just for orientation, left means patient's left, the scope is going clockwise, okay? So if the scope, imagine the scope in me. If you go clockwise, you're going to the patient's left. If you go counterclockwise, because the probe is, मुझे जो मेरे mentor थे उन्होंने कहा था imagine it's your thumb, और उसको रख के देखो कि this, the thumb अगर आपका पीछे को face कर रहा है, clockwise is to the patient's left, counterclockwise is to the patient's right. Does that make sense? Okay, so. And in these diagrams, what you need to sort of remember is the thick arrow is the direction of the scope. So the scope is downwards, pointing down on the CT, and as you go clockwise, you will see the neck structure, which will be the adrenal gland. If you go more clockwise, so you're turning even more to the patient's left, then you will go towards the spleen. Now the probe is going more towards the patient's spleen, and you will turn over to see the spleen. And it's best to just show you videos, and you're going to see live cases of this anyway. But here's that image of the aorta with the celiac artery and the SMA. And as I go clockwise, you see the adrenal gland, and if you keep going clockwise, you see the spleen. So that's all in one swoop from one area as soon as you go past the G junction. Aorta, celiac, SMA, left adrenal, kidney, spleen. That's all you can do in one quick go. I'm going to go fast on these because of time issues, and I think there's a patient waiting. When you're when you usually just go in about a centimeter, turn slightly clockwise, now you're deeper inside, and now you're going to land on the pancreas. So now you're going to have the probe basically looking down from the stomach at the pancreas. We're not actually in front, we're usually above. And you have the splenic artery, splenic vein, and you're going to see the EUS image with the splenic artery vein and the pancreas. The pancreatic duct will almost always be above the vessel. Actually, it is always above. So what happens is sometimes you'll see a little thing here which you may think is a duct, but actually that's really just a small branch of a vessel. You may be just pushing the duct down. The duct is always going to be above the splenic artery, splenic vein. And now if you go towards the patient's left, so you're going clockwise, so if this goes clockwise this way, you're going to go towards the tail. If you go this way, counterclockwise, you're going to go towards the neck. And here we have a video of this basically concept that you're on the pancreas. This is not a normal looking pancreas, but this ultrasound was not for this reason. It's not projecting very well, but as you go clockwise, you'll go towards the spleen area, and this is the pancreas. This structure here, you can see this white line is the boundary of the pancreas. And if you go counterclockwise, you'll go towards the neck. And Dr. Khalid Hassan is going to show you this in the next case that he's about to do. So then as you go counterclockwise to the patient's right, now you're going to go towards the splenoportal confluence. And the pancreatic duct is going to go on the ultrasound image from here down this way and then down this way. And as you keep going there and you big wheel towards the gastric wall, you will actually see that confluence. So there's the portal vein, SMA, splenic vein, and you're now more towards the antrum side. Your tip is really further in, and you will see that you can even see the bile duct, you can see the pancreatic duct, and you see the confluence of the splenic vein and the portal vein. So that's all from the stomach. Basically, you're looking mostly at the pancreas in these situations, right? So you're looking for these structures. I'm not talking about station 1, 2, 3, 4 for a reason, because it doesn't matter. what are you actually in there for? You're in there for a specific reason, as Dr. Yas said. You're either looking for the pancreas, lymph nodes, whatever the mass is, whatever. So focus on that, not get stuck on stations. But in your mind, you should have a checklist of things that you're going to look at. I'm going to look at the pancreas, I'm going to look at the bile duct, gallbladder, I'm going to look at the liver, I'm going to look at lymph nodes. These are the 4 primary things. Everything else is extra. Uske baad, if you see it, great. If not, then that's okay too. And if you're going for the mass, the patient's not tolerating the sedation, start with what's most important. Start with the mass. Uske baad, you can go do the other staging stuff if necessary, but at least get to the lesion of interest. This is, now we're in the jejunal bulb. Our probe is actually now facing up to the patient's left axilla. Okay, from here, you basically, if this is the jejunal bulb, what do you see here? This is the bile duct, that's the portal vein. So what do we expect to see if I mag in? Bile duct, jejunum, portal vein, S&D. What we're going to find is the closest structure to the probe is the bile duct. And behind it, this is further down, but behind it should be the portal vein as shown on this diagram. And then if you go counterclockwise, you go up towards the liver. Clockwise, you'll go towards the papilla. So downwards, you'll come towards the 2 ducts coming together. Upwards, they'll separate out. And this video will show you how that works. So basically, you'll see that there's the bile duct, there's the pancreatic duct. As I go counterclockwise, bile duct getting slightly compressed, relaxing the visual, and that is the portal vein. As you go clockwise, portal vein, bile duct, IVC right away, and then pancreatic duct will come into view with the bile duct. Okay, you're going to see this all day for the next 3 days. You're going to see these views over and over. But the key here is understanding how to get those views, and we'll go over that with you. Okay, but you should ideally follow the bile duct all the way from the liver to the papilla in the duodenal bulb. I would say in about 90% plus patients you can do that. Sometimes it's just not possible, but in the vast majority you can. And then in the bulb, depending on where you are, you can see various other structures. You can see the hepatic artery, you can see the gallbladder, and then the confluence like we talked about. You can see the kidney, but it's not of much value to you in your practice. This perhaps is the easiest to understand because we do ERCP, and this is very similar to ERCP. Now you're in the short position. Your probe is pointing directly to the patient's pancreas. So there's your view. Now remember that pancreatic duct is inferior to the bile duct as it comes in. So when you're in position, usually if you go depending on where you start, I'll show you my technique, which is always to go clockwise. Clockwise here will take you towards the front. Counterclockwise will take you to the back. Again, this is the front back. So clockwise take you to the front towards the uncinate, and from there, when you go counterclockwise, you will see the pancreatic duct, and then you keep going more counterclockwise, you see the bile duct. And if you keep going counterclockwise, you'll follow the bile duct. So if you keep going counter, usually you'll follow the bile duct. For pancreatic duct, depending on where the duct runs, sorry about the quality of the images, but you can actually track it backwards towards the neck of the pancreas. So in this video, you'll see the probe is now, I usually start in the uncinate, go clockwise, I'm going all the way clockwise. You can see the mesenteric duct, PD first, bile duct, and I'm just gradually pulling back as I scan. Bile duct going upwards, and then I'm going to go clockwise again. There's my PD again, just trying to understand and see what's going on here. And you'll see as I keep pulling back, I'm looking both at the PD and the bile duct. Here I see that the PD is now going in a different direction. So this may be deviation, but we don't need to get into. But the point being that you can follow these ducts both to the minor and the major papilla. In this case, this patient actually has deviation. Okay, so just quickly, I had to rest through it. Don't lose hope. That's the message number 1. Number 2, repetition is key. Understanding improves with case volume. I cannot emphasize this enough. The more I do it, the more I learn new things that I'm like, oh man, I mean, this is something new I just realized. Review imaging, again, cannot emphasize. Aajkal ke zamane mein, it's not necessarily this whole issue of hopefully a lot of films that people carry around. If they do, you still should try and look, but generally speaking, CT khas taur pe, if you have it available, somehow get your hands on it, look at it, because that'll help you target where you need to go. It's a dynamic procedure. शुरू में ही होता है कि because we just had new fellow start, scope अंदर डाल दिया है, वो खड़े में है, इधर थोड़ा सा उधर कर दिया, and I keep telling them, you have to move your scope around. Ultrasound is not like ERCP. ERCP, when you get to the papilla, you stand there. Here, in order to find a lesion, find a structure, you have to move your scope around. So the tendency is to just freeze. You know, in any new activity, we tend to freeze. As we develop skills, our fluidity comes in. So that's something to remember. Sorry, this is out of order. If lost, identify key structures. Agar aapne CT dekha and you know it's to the left of the portal vein, then identify the portal vein. If you find the portal vein, then you can find your lesion. So there's a correlation between like looking at the map and then going on to the sort of your hike. Bagair map ke chal padenge, to obviously we're going to get lost. Utilize available resources. There are a lot of online videos, US courses, books, etc. Obviously, we are even, ek to ek khair, you have mashallah se great experts here, but even after we leave here, we'll share Khalid Bhai's cell phone number with all of you. Feel free to call him anytime, any hour of the day. The guy doesn't sleep, so he can answer your calls and help you in any case. And that, I think, is pretty much it.
I'll tell you,